Hello everyone and welcome to the first ECG round. It's a very pleasure to introduce this first appointment on cardio education line in which we will speak about the interpretation of your electrocardiograms. Before to introduce our speaker, Professor Roberto Santilli, I would like to remember you that you can use a Q&A session to post your questions. If you are following by Facebook group, you can post questions in the comments. We will keep in post to our speaker all your questions at the end of presentation or during after the cases. Now, I'm glad to introduce you Professor Roberto Santilli. Roberto Santilli graduated from the College of Veterinary Medicine of the University of Milan in 1990. He became a diplomate of the European College of Veterinary Internal Medicine, Companion Animal Specialties of Cardiology in 1999. Between 2004 and 2006, he completed the Master in Electrophysiology and Electrical Stimulation at the University of Medicine of Insubria. He then obtained a PhD at the University of Turin, College of Veterinary Internal Medicine in 2010. Roberto Santilli is the head of the cardiology department of the Clinica Veterinaria Malpensa Nicure in Samarate Varese and of the Ospedale Veterinario Portoni Rossa Nicure Bologna. Since 2014, he has been an adjunct professor of cardiology at the Cornell University College of Veterinary Medicine, where he is actively involved in the activities of cardiac electrophysiological laboratory. He is a co-author of the book Electrocardiography of the Dog and Cat, now translated in 9 languages. His main research activities include the diagnosis and treatment of arrhythmias in dogs and cats. Welcome again, and we can start with the presentation of Professor Roberto Santilli. Thank you.
Thank you very much, Arianna, for your kind introduction, and welcome everybody. So tonight we will discuss your ECG. Thank you for sending us a bunch of ECG, and we will try to discuss each one. So at the end of the ECG, of each ECG, you can just post your question in the Q&A or on Facebook, and we will try to discuss the ECG together. So let's start with this ECG. This is a cat, 9 years old, and 3.4 kg, and was referred for an episode of syncope. So here we have lead 1, 2, and 3, AVR, AVL, and AVF. And so let's start looking on the QRS complex together. So we can see for a cat a wide QRS complex. So there is a tiny changes when you compare different QRS complexes, but mainly it's wide. Wide means more than 40 milliseconds for cat. And so when you have a wide QRS complex, the first things to rule out is ventricular arrhythmia. So what you want to do is just check for atrioventricular association. And so we can start from here, and I see a P wave before the QRS complex. Then I see here another P wave, P waves, then another here, here, here. Here I can see 2, but obviously is an artifact because the one cannot be one on a, I mean, 2 closed. So it's just one here, and then here what happened? We have different. It looks like atrial activation here, but in my experience, that probably not true. So just can be some either artifact or an atrial ectopic foci that is firing here at this rate. Then another here, 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 and then we have a drop P wave here and suddenly stop and then start back here. So if you look at the PQ interval, it's very similar. So maybe there is just a slight increase here. So it's a first degree AV block, but I can consider this an AV association. That means that this is a normal conducted QRS complex, and so it's a bundle branch block. in our experience, when you have a normal axis on the frontal plane, this is a left bundle branch block. So as soon as you see a left bundle branch block, now we have to say if it's a complete one or pre-divisional, so before the bifurcation in anterior and posterior fascicle, or is this a incomplete left bundle branch block, so more post-divisional, so after the division. So what is very important that you remember that the activation of the septum that usually induce a Q waves in lead 1, 2, and AVF. So 1, 2, and AVF. Usually the presence of Q waves can suggest the presence of the first vector, so meaning that the two fascicles are working. In this particular case, we don't see Q waves, so it's very likely that the block on the fascicles is before the bifurcation. So we call it truncular left bundle branch block or bifascicular left bundle branch block because two fascicles are involved. So when two fascicles are involved and you also find the presence of second degree AV block either here or here, this means that is a trifascicular block. So here we have two fascicle block, and here during the focal atrial attack, or here when you just have one bit drop, this is also the right bundle is blocked here. So you have what we call trifascicular block. So it's very likely, we publish a paper that I'll show you in a minute, that when you have a trifascicular block in CAT, the presence of underlying myocarditis is very likely. Or if it's an old CAT, you can consider the presence of maybe myocardial disorder or AV conduction disorder. But again, this is a truncular block, so a bifascicular block, anterior and posterior fascicular block, together with second degree AV block. So it's a trifascicular block. And here you can actually see in a different speed, again, you can see the presence of P waves here, but then in some point, so this one here, 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 they are all conducting. There is one right here that looks that is not conducting because the P wave is dissociated from the Cures complex. But despite the morphology is very similar, this one should be considered ventricle in origin. So when you have a pre-divisional block, just a truncular block like this, there is the loss of the first vector. So the first vector, the septal vector that is moving inferior to superior, left to right, and posterior to anterior is lost. So you can actually rarely see the second vector, so the right ventricular vector. Usually is a tiny vector that can induce a Q waves in inferior lead, but usually it's a very, very tiny Q waves. And then you have a delayed third vector with a normal axis, and that's what you usually see. So the block is here. You can either have in a truncular block no Q waves because you usually don't see the second vector, or you can have a tiny Q wave because you are actually seeing here the right ventricular vector, and then you have a delay left ventricular vector. What is very important, remember that we already discussed in other rounds the R peak time. So you see the reach of the R in lead V1. So this is V1, so it's the lead of the right ventricle. You see it's very early compared to the reach of the peak of the R in the left precordial. So you see here it's a long distance between the reach of R peak time in lead V1 and in lead V2 to V6. So again, 1, 2, 3, AVR, AVL, AVF, V1, V2 to V6. This is usually using our system. And this is the paper that we published. For the one of you that want it, we can send it to you. This is in. We actually did this spring and a live on Instagram where we discussed this paper. But what is nice, I think, that we published this table where you can find for cat all the different AV block, and starting from a normal, going to the right, left posterior, left anterior, bifascicular, so anterior and right, or posterior and right, or truncular left bundle branch block, post-divisional, and trifascicular. And we place here for you all the axis and the deviation and the QRS complex duration. Remember that usually monofascicular block are usually narrow QRS complex, just like the left anterior fascicular block, or incomplete right bundle branch block when the block is more distal. But then when it's bifascicular, such as in this case, it's considered wide, so more than 70, actually 80 in dogs milliseconds, and more than 40 milliseconds in cats. And this is another paper that we published is an ECG of the month on JAVMA. Again, these are all our lead from V1 to V6. And as you can see here again, you see a wide QRS complex with a tiny Q and a wide QRS complex with a normal axis. So it's a truncular left bundle branch block, bifascicular block, and then suddenly a second degree AV block. So this is a trifascicular block. Again, trifascicular is when you have a bifascicular with a second degree AV block, or when you have an alternation of right bundle, left bundle, and in a same tracing on a different tracing. So in a case like this, what we do, we wanna have troponin I that usually is very, very elevated in acute myocarditis. This is usually you see this type of ECG in cats with the transient myocardial thickening due to edema. So it looks like hypertrophic cardiomyopathy, but it's just edema. And then within 1 month, usually you have a normal conduction, so that you can actually see a disappearance of the AV block and also a remodeling back to a normal thickening of the left ventricular wall because the edema disappeared. So this was a very interesting ECG. Thank you, Sarah Shazal, to sending this to us. And this is from another colleague, Andrei Bison, and we put it here. This is a 16-year-old dogs with a pulmonary hypertension, and this dog died a few days after starting an antiarrhythmic treatment. And here again, I think it's very similar to previous ECG because we have from V1 to V1, 2, 3, AVR, AVL, and AVF, and then V1 to V6. So it is using our system because I can see a normal axis for V1 and from V2 to V6. So again, we have a wide QRS complex. When you have a wide QRS complex, rule out ventricular arrhythmia. 90% of the time is a ventricular arrhythmia. In this case, is not, because I can see a P wave in front of the QRS complex with a normal PQ interval. So this is probably a bundle branch block. Is this anatomical or is this aberrancy? Aberrancy you have to remember that is considered an a bundle branch block due a change in the rate. And this is not the case because you also have in a long RR and in a short RR, you have the same morphology. So when you have atrioventricular association, it's enough to consider a supraventricular rhythm conducted with either anatomical bundle branch block or functional bundle branch block or aberrancy. Since you rule out changes of the morphology of the QRS complex related to the changes in the rate, this is an anatomical intraventricular block. So what happened here, we have to try to understand what type of intraventricular block is, so what type of bundle branch block is. And so we look at the axis. It's a normal axis on the frontal plane, and it has a normal axis on the horizontal plane, so negative in one and positive from V2 to V6. So this is a left bundle branch block. Is this pre-divisional or truncular or post-divisional? Again, I can see a tiny Q wave that probably is the second vector. I cannot see a deep Q wave that is usually present when you have a normal first vector. So this is a pre-divisional left bundle branch block or truncular left bundle branch block. So remember, this is a bifascicular block. When you see something like that, you have to keep in mind that the electrical impulse is going from the atria to the ventricle along the right bundle. The right bundle is a tiny bundle, and usually the vulnerability of the bundle depends on the length of the bundle and the wideness of the bundle. And usually the left anterior is the more vulnerable, followed by the distal part of the right bundle. And then you have the posterior bundle, and then you have the truncular part of the left bundle. So when you have a truncular block like this one, it's already an indication for possible pacemaker, for a possible need of a pacemaker, because it's very likely that when you have something like that, it can go into third-degree AV block. We have several experiences. So when the use of beta blockers in the therapy of congestive heart failure is very controversial. There are people that wanted to use it. There are people that don't. In human, it's the gold standard for treatment. The only thing for this particular case, I can see for following that as being used because this dog had an focal atrial tachycardia. As you can see here, it goes from a normal sinus rhythm, and suddenly you don't see P waves because are inscribed in the previous QRS complex, but the morphology of this QRS complex is exactly the same of the one during sinus rhythm, as you can see here and here too. So it's very likely that this is a focal atrial tachycardia. That's probably the reason why they gave atenolol that can be used as a beta blocker in catecholaminergic SVT, particularly focal atrial tach. My only worry is when I have a complete or truncular left bundle branch block that you can induce more damage on the right bundle, and then you can induce a third-degree AV block. And this is how the tachycardia stops. As you can see, now you see a tiny P waves, and then you back to a normal sinus rhythm with the presence of a normal AV association. Remember, because for the one of you that were here a month ago when Dr. Perego discussed about the differential diagnosis of wide QRS complex, it's very important to consider before looking at the morphology always the presence of AV association, and this is the case. So it's very, very important to understand the algorithm that you need to follow. So first of all, wide QRS complex, ventricular. So the second step is to look for AV association. If there is AV association, is supraventricular. And then you look for anatomical bundle branch block or functional bundle branch block. So it's very important to move forward. And when you do not see any atrial activation, so you cannot say, for example, in a case like this one here, let's imagine that we just had this type of ECG. You cannot see P waves here. In such a case, you need now to look at the morphology as we did here. So it's positive in 1, 2, 3 and AVF. So it's a left bundle branch block type. So I want that now 1, 2, 3 and AVF should be similar to from V1 to from V2 to V6, and then AVR should be very similar to V1, and that was the case. So it's very interesting cases. Thank you so much, because bifascicular block in dogs is less common than in cats with myocarditis. Is there any questions you want to do for this part of ECG before moving forward? And here is again, you see now the tachycardia. That was a focal atrial tachycardia conducted with truncular left bundle branch block, but it's not an aberrancy, because we also have wide QRS complex during sinus rhythm. Obviously, when you have an AV block or a bundle branch block, and you have the presence of sustained fast rhythm, then you can also have more bundle branch block. So there is a kind of aberrancy on top of an anatomical block. Manuela, is there any question on this?
Just one question. Hi, everybody. So if you look at the second slide of the second ECG, okay, this one. So if you consider, not the previous one, if you consider the morphology of the QRS complex in V2, there is a slight difference between the first two bits and, for example, the third. Do you consider just artifacts, or do you consider an alteration in the conduction of the impulse along the intraventricular septum?
Okay, so what I can say that probably this V2 is also reading the interventricular septum. Remember, when you have the isoelectric, the presence of isoelectric lead, just like this one, you're reading the septum. So it's not exactly on top of the left ventricle as it should be. So that's probably why you have this type of QRS complex morphology. This variation that you can see here, you can actually see also in other part of the tracing. You see, this is this. So when you have bundle branch block due to either an inflammation or degeneration, you can have different amount of block. So when it's more, you have a wider and taller QRS complex, and then when it's less, you have less block, it's a little bit narrower. It's important when you have no change in the rate. When you do have change in the rate, just like this one, actually this can be an aberrancy. You can actually have aberrancy, so functional block that it goes on top of an anatomical block. This can happen. Also, if you have a VPCs with a short coupling interval, you can have an aberrancy on the conduction with these VPCs. So the functional block is, when it's alone, is just rate related, but you can actually have functional block on top of an anatomical block, such as in case like this. And so you can see that it's changing the morphology because you have different degree of block along the interventricular septum. That's why it comes from positive to isodiphasic, depending on the amount of block.
Okay, thank you. We have another question regarding the first ECG, so from Sarah, and she said that troponin I was within normal values for this cat, and standard echocardiography was within the normal values. So, which can be the explanation of this type of ECG, seeing the troponin I values and echocardiographic values?
As I told you, usually we found trifascicular block in cats with acute myocarditis and transient myocardial thickening. This is the case where you see troponin very, very high level. So you can actually see 10, 20 of troponin. If you see something like that in a cat with normal troponin and normal cardiac echocardiography, so normal echocardiogram, this is usually a conduction block. So in cats, a conduction disease. Usually in cats, AV block is related to different cardiomyopathy. So there is just a very old review where there is an association of AV block and cardiomyopathy, different types, so restrictive, hypertrophic, and so on. But there is also cases where you can actually have degeneration of the conduction system, just like the Lev or Lineagre disease that you can see in dogs and in humans. So if you have a normal troponin and normal echo, this is a case where a conduction disease, a disorder is present. Usually in a case like this, we do Holter, and if the Holter present prolonged ventricular asystole, we start using aminophylline, and usually there are very, very few cases in CAD that need pacemaker implantation, very rarely. But this should be considered a possible option if, despite aminophylline, if you still have syncope and prolonged ventricular arrest. But we have to say also that the prognosis in cats with AV block, if you look at the literature, is not the same of dogs. Dogs, I mean, 60% of dog dies within 6 months from the diagnosis after having a diagnosis of second degree or third degree AV block. Cat can actually live years with these disorders. So it's not as common to have sudden death as in dogs, but still, if the symptoms remain despite the use of aminophylline, we like to put epicardial pacemakers. Okay?
Thank you very much. We can move to the next case.
Okay, this is another case from another colleague, Hamhed Mozem, oh my God, it's too difficult to pronounce it, Ibrahim. And so this is a Schnauzer male with an arrhythmia. It was referred for arrhythmias and a stage D mitral valve disease, so an advanced mitral valve disease. So what we see here is a tachycardia with a narrow QRS complex. You can see here the 1, 2, 3 AVR, AVL, and AVF, and then there is lead V. But so it's a narrow QRS complex, so it's a supraventricular rhythm, tachycardia. Actually, there are periods where it's tachycardia alternating to periods where you have more bradycardia. So since it's a narrow QRS complex, which are our differentials? So the first one, when you have irregular interval, is to rule in or rule out atrial fibrillation. And so look for the presence of F waves. But here, as you can see, there is monomorphic F waves with a very fast atrial rate, and the cycle length is very regular. So to me, it looks like an anatomical reentry. So my first differential is atrial flutter. But be careful, because sometimes coarse atrial, when atrial fibrillation is paroxysmal, it can still have something that looks organized, just like this one. So remember, lead 2 is reading the interatrial septum. Lead AVL is reading the left atrium, and lead V1 is reading the right atrium. And the right atrium is not fibrillating because it's very organized. The left atrium is not fibrillating because it's well organized. And the interatrial septum is not fibrillating because it's organized. So the other thing that you have to do right away is to measure the FF interval. Remember, in our experience, all dogs that have an anatomical atrial flutter should have an atrial rate less than 500 beats per minute. So this is very, very important, because you can have something that looks similar to this in paroxysmal atrial fibrillation, but the rate, it's above 500 beats per minute. So be careful, because I've seen cases that can be there is a incorrect diagnosis of atrial flutter, and it's not. So when you call atrial flutter, you have to consider an anatomical flood, an anatomical reentry, usually within the right atrium. So usually the only one that we see that has this type of appearance that we call sawtooth pattern of appearance, this is usually the cavo-tricuspid isthmus dependent atrial flutter. So what is this? And we will see in this slide. So we have different publications that we did in the last few years. So the first one is the cavo-tricuspid isthmus dependent atrial flutter. So this is a dorsoventral view. This is the coronary sinus catheter, and this is another catheter. It's along the crista terminalis. So to understand, this is the sinus node, this is the mid crista, this is the low crista, and this is the coronary sinus ostium. This is the area of the cavo-tricuspid isthmus. So the cavo-tricuspid isthmus is an area of slow conduction between the entrance of the caudal vena cava and the septal leaflet of the tricuspid valve. And this is where there is the classification of flutter, is according to the positioning of the isthmus, so the area of slow conduction. The only one that we see with a sawtooth pattern of activation is what we call the typical atrial flutter, that is moving like this, counterclockwise. So let's imagine that this is a clock, 12, 6, 3, and 9. So we have something low in the isthmus and then back like this. So counterclockwise. This is probably what is the case of our colleague. Then in the same case series, we also found dogs which we call typical reverse atrial flutter. So it's a flutter that is going clockwise. So it's moving in the isthmus, then exactly as the hour clock time. So like this, clockwise. So if we go back here, this type of appearance, it's a sawtooth pattern of appearance. The atrial rate is less than 500, better less than 450 beats per minute. It's monomorphic with a regular RR interval. This is very important because this is considered an anatomical flutter. And because he has this type of appearance that so far is the only one that we found like that, this is considered a typical, so with a counterclockwise activation pattern. So this is a very, very interesting. Tracy, thank you. I'm happy to send it to us. And from the same colleague, we have this other type of arrhythmia. Very, very interesting. This is a pit bull terrier. It's a screening ECG. So what do you see here? So here we see something interesting because we see this narrow curious complex, like this one here. But then in the descending part of the curious complex, there is this type of alteration here, 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 that is coming out here, 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 and look how, oh sorry, how nice is here. So what it can be, so there are different options here because there is another thing that you should consider, that this type of T is variable if you compare this with this, with this, with this. So it can either be a sinus rhythm with some form of fragmentation, or what we call a slurring of the curious complex. But I think in my experience is too much to be considered that. So the other option is that for some reason we have a fast tachycardia, so we have different atrial activation like that, so but with isoelectric line between them. To do the differential diagnosis, we need to do a Holter, and with the Holter we can rule in or rule out the possible presence of an atrial flutter or the presence of just a fragmentation or slurring of the curious complex. To me, it's a little bit suspicious because it's changing too much on a bit-to-bit basis. And if you look here even more, here, here, here. So I really think that we need a Holter to rule in or rule out the presence of a flutter. So let's assume that this is a flutter. And if this is the case, we have isoelectric line between consecutive F-wave. So which are the options? The other two. So we published some years ago atypical. So all the different flutters with the isthmus that is located in an area other than the cavotricuspid isthmus should be considered atypical. And this was a case where the flutter was interatrial septum. Then we have another isthmus in the right atrial free wall. And this year, we just published what we call cranial vena cava flutter. As you can see here, this is a lateral view, and the isthmus was where we did the ablation was within the cranial vena cava. The appearance can be slightly different from that, so you can actually see the F wave coming in and out from the QRS complex, but what is interesting is the isoelectric line between two consecutive F waves. So I'm not saying for sure this is a flutter, and it's suspicious because of this changing. I really need a Holter and to see over a 24-hour what happened. If this is a flutter, it will change, and so we really need to see this atrial activation coming out of the QRS complex because there is a change in the AV conduction. All right, there is any question regarding these arrhythmias?
Okay, which type of antiarrhythmics do you consider in case 3, so in the dog affected by mitral valve disease stage D with normal right ventricular and left ventricular function? And which options do you consider in ECG4 with normal echo?
All right, this is a very good question. So which are the drugs that we can use to stop flutters? So we really need to use what we call isthmic blocker. Which one? So the best one is sotalol, and the other one is amiodarone. So sotalol, remember we already discussed it, has a two action, beta blockers and class 3, and we don't know exactly when one or the other starts. So for sure at low doses we do have beta blocking effect, and at higher doses we have a class 3, but to stop the flutters we really need class 3. So what's the problem? That we use a drug that we want to use class 3, but we are also using class 2, so a beta blocking effect, and I really don't like to use in a beta blocking effect if there is a severe end stage congestive heart failure, just like in this case. So I'm a little bit worried in using a beta blocking at this stage, a class D of the ACVIM consensus classification. So if I really do need to do a Holter and see the average R rate, and if the average R rate is under control, I would rather consider using digoxin in a case like this. I know that sometimes digoxin can actually induce atrial fibrillation because it's vagotonic, but in a case like this with a very, very high sympathetic drive, it's very unlikely. So I would like to use a nodal blocker, so I don't want to stop the flutter, just like using sotalol, but I can slow the ventricular rate. Or it can actually go into a fib, and then I control a fib with digoxin. So my first choice would be digoxin. I'm not sure using amio in a case like this because it's already, class D, so it's not eating. And if we add amio, it's going to be even worse. Then, if we treat a normal echo dog, that's the case we really need to use sotalol. What we do before using sotalol in a case like this, I want to be 100% sure that this is the case. And actually, I don't know, obviously, as you know, ablation is not an option in a lot of actually countries all over the world, other than few of them. But we really like to do ablation in case of flutter in normal echo because flutter is a very difficult arrhythmia to control. But in a case like this, you should use sotalol, increasing dose, if you have the diagnosis of atrial flutter, then so you can actually add sotalol on board, and usually in such a case we like to start just with the testing dose, so maybe 1 mg per kg twice a day, and then the day after, if he's not having any, because the dog that they do not handle the beta blocker, after the first dose, they can actually have very, very weak, very, very bad weakness. So if it's not the case, that you can actually go up to 2.2, 2.5. In our experience, 2.5 is enough to stop flutters. Don't use sotalol if you have congestive heart failure due to right side failure. So if you have right ventricular systolic dysfunction, don't use sotalol. It's not the same if you have left ventricular systolic dysfunction. I think they can handle better, but if you use sotalol in a right ventricular failure and a right ventricular systolic dysfunction, you can actually either induce sudden death, and we have seen it, or you can actually induce congestive heart failure, and I've seen it. So you have cases where after 2 doses of sotalol, they go into ascites, or even worse, they can actually die. So, but if a normal echo or left ventricular systolic dysfunction, they can handle quite well sotalol.
Thank you very much. And Catherine Partington is asking regarding this ECG, so ECG4, would it be wrong to have isorhythmic AV dissociation with a junctional rhythm as a differential diagnosis?
Okay, this is a good point. The only thing that is very, is very unlikely, that usually with junctional tachycardia, the PQ interval is variable, and this is not the case. As you can see here, if this is a P and this is a fragmentation, this is always the same. If it's not a P, it's an F with a 2-to-1 or 3-to-1 AV relationship, then it should be always the same. But in junctional tachycardia, this should change. So in isorhythmic dissociation, I want to see PQ variable, or in case it's a synchronization type 1. But if it's a synchronization type 2, the P and the QRS complex are very close. So you just, it's very close, but then if you look carefully, they move.
So why in your
sorry, say again?
Why, in your opinion, the positive deflection on the descending branch of the R wave cannot be considered an atrial deflection?
No, I'm not saying that. I'm not saying that. I'm saying yes, but if there is AV dissociation, also this one should change, not just this one. It should change also this one. So in this case, what is changing is just this one. So because there is some form of fragmentation that changes over time, or there is an atrial activation inside this area. I'm not 100% sure. I need a Holter. Before giving anything to this dog, I really need a Holter to be sure. Because if this is just a fragmentation, I mean, you don't need to do anything. No, you just need to follow up.
And just talking about sotalol, can be sotalol used in dogs with arrhythmogenic cardiomyopathy with right heart systolic dysfunction, in your opinion?
This is a very, very, very good point. I mean, it depends on the amount of dysfunction and the presence of congestion. We really had several problems particularly with English bulldogs, with sotalol. Just if they have flutter or if they have VTAC and you want to control VTAC. We had cases where they weren't in congestion, and after a few doses, they actually went into right heart failure. And what I have to say that arrhythmogenic cardiomyopathy is very common in boxers, English bulldog, and they can handle amiodarone for years without problems. So if I have any doubts, since I've seen dogs dying for sotalol with the right ventricular systolic dysfunction, I mean, I'm talking about severe right ventricular systolic dysfunction, not just the aneurysm of the right ventricular outflow tract. So if you have a global dysfunction of the right ventricle, is not our first choice. We prefer to use amio because we are more confident on the control of the rate, and on the other part, looking at there is less side effect.
Okay, thank you. And can we move just 1 second to the second case, so ECG2, because Andrei Baisan is just asking, instead of beta blockers, would have there any other antiarrhythmic treatment that could be used to reduce the SVT runs?
This is a good point, Andre, because this is a focal atrial tachycardia. So in a dog with AV block, with intraventricular conduction block, and actually a severe conduction block. Again, here, if you use mainly either atenolol or sotalol, I don't think it's a good choice because we can actually induce more advanced block. So we know that ivabradine, we are using it a lot of focal atrial tachycardia cases. There are some where it's fantastic, other one where it's not. Has been shown in human, if you look at the literature, that ivabradine can induce AV block, but this is not what we actually see in different cases. The only thing about ivabradine that I've seen, rarely, you can have cases where it can induce atrial fibrillation, particularly if you have already a increase of the left atrium sides. So my first choice would have been in this case ivabradine, but with a careful, in a case like this, what I suggest if you want to use, because the Holter is showing you severe SVT and blah, 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 it's important to do a Holter during the antiarrhythmic test. So starting very, very low, looking at the Holter, what happened. If you see a worsening of the conduction along the AV nodes, because he has already a bifascicular block, you just stop the drugs. So I really like, we usually, for all the arrhythmias that are sustained, either ventricular or supraventricular, we like to monitor with the Holter, also with telemetry, but I think it's much better a Holter because you can actually go back and see what happened at the peak of the different drugs. So my first choice would have been ivabradine if the Holter has a arrhythmia burden very, very high. Otherwise, I really don't like to have a risk in case like this. If he has already bifascicular block, I don't want to add drug that can compromise the right bundle. And we know the right bundle is very vulnerable to block. It's very easy to block. So that's why we are very, try to use antiarrhythmic very, very in a controlled state during Holter.
Okay, thank you. And just moving 1 second to atrial flutter. So Kostas Varkulis is asking, what is your opinion or your experience in the use of ibutylid, so a class 3 antiarrhythmic of the Vaughan-Williams classification?
Okay, so either we are having right now problem in using drugs where, we know for human that are wonderful because ibutylid is a class 3 agent that has been shown in human that is fantastic for oral cardioversion in flutters and AFib, and also class 1C agent, just like propafenone or flecainide, can also be considered a very good drugs for humans. If you go in the literature and you look for PK/PD, so pharmacodynamic and pharmacokinetics of these agents in dogs, are just experimental studies, mainly looking at the toxicity and using IV drugs, and very rarely with oral drugs. So we are a little bit skeptical in using drugs where we don't have a very good PK/PD. That's my only worry. But for sure, as we did for ivabradine, there will be space or room to use new drugs as soon as we have more data on PK/PD.
Okay, thank you very much. We have some 9 minutes just to have a look at the last ECG.
Okay, so maybe we can go fast in this one to finish the one of this colleague. So this is a cat with pericardial effusion and a bradyarrhythmias, and this is a narrow QRS complex for a cat, less than 40. and it's an irregular RR interval. And when you go here and you look on the isoelectric line, it's fibrillating. So I think it's an atrial fibrillation. It depends. In cat, it's very rare to see a sustained and a persistent atrial fibrillation, but can happen. And sometimes, for some reason, is not tachycardic. So usually we do Holter, and if it's a fast rate over time, we like to use digoxin every 2 days. And most of the cats we use in digoxin, they can actually cardiovert back to sinus rhythm. So maybe we can just, if we have enough time, we can just finish up with these dogs. And this is a 3-year-old dog hospitalized for neurological problems, tetraplegia, and he died during night. So this is a telemetry, I think, and you can actually see these dogs is considered just like lead 2, is a faster rate, but what I can see in this particular dog is the ST segment that is severely depressed over time. And sometimes with tachycardia, it can happen. What I don't like if we remain also with normal rate. And you can see over time here, you see that the ST segment was severely depressed also when the rate slowed down. Then here, this is not consecutive because this is 12, and then here it's another time, so it's 4 p.m. Here now, the depression is a little bit better because you can see there is a V association. Then suddenly you have a sinus arrest. So it's very irregular. It's not progressive enough, but it's still, you see there is some alteration. In my experience, this is not a vasovagal, because usually for vasovagal, I want to see a progressive slowing, but without recovering. You see here, you have a sudden recovery of the rate. This looks like just an imbalance between the vagus and the sympathetic drive. And this is usually, in my experience, due to probably cerebral problem, maybe high cerebral pressure or something like that, because you have slowing and then fast, slowing and fast. And this cannot be, maybe this can happen obviously with sinus node dysfunction, but I don't think this is the case because you have period where you have a completely normal rate. And then you see here that these imbalance get worse and worse, and then suddenly you have escape ventricular rhythm like that, because probably he has a very, very high intracranial pressure for some reason. I don't know why it was, I don't know about, maybe he can tell us if he has also central symptoms. And then you see suddenly the vagus is actually taking control, and you have mainly a ventricular, very low ventricular rate. This is usually a precursor of what we call electromechanical dissociation, that is actually pulseless, electrical pulseless activity, and this is usually the end stage for, most of actually some of the cases that we have. Then after this long period where you have a very slow ventricular escape, suddenly you go back with a junctional rhythm, and then it's probably isorhythmic here because you have P and QRS complex very close, so it's a probably junctional rhythm. And then after a runs of VTAC, then you got a systole and electromechanical dissociation. So in my experience, I've seen cases like this usually due to a central problem. Obviously, we rule out sinus node dysfunction for different reasons. First of all, because of he doesn't have this type of symptoms, and second, because it's a very young dog, and he has probably central nervous problem. And this is the classical appearance of agonal rhythm, just like pulseless activity. And this is the end. With this, it gets wider and wider. no atrial activation. And this is the last part. So there is now, we just published a paper on heart rhythm characterization during sudden cardiac death in dogs. It will be, this is just the pre-proof, so you can just see the, the correct proof. But what is interesting that we found, as you can see here, that 42% of the dog died for ventricular fibrillation, 21% for torsade de pointe, but we have 37% that died because of agonal rhythm. So they die because they have inappropriate and malignant high vagal tone, inducing vasovagal syncope and then sudden cardiac death. We will discuss this paper probably either on Facebook or on Instagram in the next months, and I will post on our either Instagram or Facebook. We will post when it's gonna be ready. Remember that as soon as it's for the first few weeks when it's published, you can actually download for free. I don't remember if it's 4 weeks or 6 weeks, I'm not sure. So as soon as it's gonna be available, I will put it on Facebook so you can actually download it. And I think it's interesting because this is the first study that characterized heart rhythm during sudden cardiac death. This is 19 dogs. I mean, it's a discrete number of dogs. Try to have something also for our patients. All right.
So Andre is asking that because the last dog was suspected of polyradiculoneuritis, so with tetraplegia. So in your experience, is this neurological disease associated with the sinus node imbalance or not?
Not sure that there is this type of association. But what is weird that we know that sinus node dysfunction is very unlikely that degenerate into agonal rhythm. So we never saw it. So we don't. Do you know if he had the cerebral fluid analysis in this dog? He's not answering.
No, it's not.
I mean, the behavior is more of a concomitant central disease, but obviously we cannot completely rule out any other option. So what is weird, obviously, again, it can look like sinus node dysfunction. The problem is that it's actually moving from something like that where, I mean, the sinus node is stressed out, then it slows down. So this is a normal functioning of the sinus node. And then suddenly it starts to work improperly. So this is, I think, it's more like an imbalance of the autonomic more than an imbalance of the sinus node. So it's just responding wrongly on the different activation, central activation of the vagus and
yes. Actually, the dog did undergo to cerebral fluid analysis. And in your experience, is polyradiculoneuritis associated with the imbalance of the autonomic nervous system? So not just on the sinus node structure, but on the balance between parasympathetic and sympathetic tone.
I mean, honestly, I don't know because I'm a neurologist and I'm really interested in this tracing. We will discuss with our neurologist and we will publish. Maybe if you put this case on our webpage, maybe in the Facebook group, maybe I can actually talk with our neurologist and try to find something about this correlation between polyradiculoneuritis and either sinus node dysfunction, to me very unlikely, or very likely central problem, because I really don't know if they have just, peripheral disorder or can also have something concomitant. And I don't know if how you have to do this differential if you don't do electromyography and blah, blah. I mean, I really don't know because I'm not a neurologist. So, but I will ask if you, Henry, if you put this on Facebook, we will try to make our neurologist to answer. She's very good in actually in peripheral neurological problems, so she will answer about this. Very, very interesting, Tracy. Unfortunately, we couldn't review all of them, so there is this one. Maybe we will do next time. And there will be also another one about this. It was an isoarrhythmic heavy dissociation, but we will do next time. So thank you again to spend this hour with us. For next time, we will do some clinical cases. So again, we will try to do some of ours. If you have nice clinical cases that you want to discuss with us, I will post, again, when to send it to us, just like you did with the ECG tonight. You can just send us the Signamen, clinical signs, echo, ECG, and what you did with treatment. So we can just discuss together what our cases and your cases. So again, thank you very much for your participation to our meeting, and I hope you enjoy this ECG round discussion. Thank you. Bye-bye.
Thank you.